Hi, how are you? Thank you all very much for coming. I'm Angela Clayton-Lea. I'm Chief Operations Officer with CTI. So just very quick, some thank yous before we get our morning started. So firstly, on behalf of our CEO in CTI, Evelyn Monroe, and our senior leadership team, it's my privilege to extend a very warm welcome to you all today to this event. And thank you also to everybody attending online. Also, thank you to everyone who accepted our invitation to speak today and present, and particularly to our overseas speakers who kindly accepted our invitation. So, when Professor Michaela Higgins reached out to myself and Professor Seamus O'Reilly last September to suggest that we merge the ISMO Research Day with our Cancer Trials Ireland National Training Day, it was a very easy yes, because as many of you know, collaboration is really at the heart of what we do in CTI. So we received 55 abstracts from NCHDs, which was a wonderful response. And we would encourage you all to take some time to view the posters that will be on display in the exam room upstairs, where coffee and lunch will also be served. So the event is growing year on year. We are maxed out this year at 185 in-person attendees. So it looks as if we're going to have to book a bigger venue next year, which is great to see that growth. Also, in tandem with that, the number of patients participating nationally in clinical trials is growing year on year. So in 2023, we had 1,860 patients, and we just got our figures for 2024. We've had an increase to 2,808. So really significant, and well done to all involved in that. Brilliant. Thank you. Our team in CTI has also been very busy during the year, a lot of changes, and I would really like to thank our team for embracing all of the changes that have been brought in. Particular thanks, I have to say, to Olivia McLaughlin, who has been intrinsic to the success during the year. Sincere thanks to our sponsor this year, Daiichi Sankyo, who have kindly agreed to sponsor the event for a second year. And finally, I hope you all enjoy the programme that Seamus, myself, Professor Higgins and Dr. Michael McCarthy have put together for you today, and I'll hand over to Seamus now to say a few words. Thank you.
Thanks very much, Angela. Today is a combination of several years of trying to integrate trainees more into how we work in Cancer Trials Ireland, and exposing what we do to the training environment. We have a presentation later this afternoon about our plans for our current plans and what we're doing with trainees, and our future plans of what we're doing for trainees. So it's great to see so many people here today. It's great to see so many new faces here today who I don't recognise, because that says we've a growing community, and that's the future of any enterprise, which is important. I'd like to take the chance to acknowledge three people here today, Jerushka and Gronyo Kane, whose initiative this was last year. So the first National Training Day was last year, so thank you both very much. And I'd also like to thank Angela for her huge work in making today happen. She's been a significant driver, and her organisational strengths are wonderful and she is wonderful to work with. So thank you very much. Without further ado, I'll hand you over to Michaela Higgins, the President of ISMO.
Morning, everyone. It's just lovely to be here. I think this is perfect timing. What better way to kick off a long weekend and to celebrate Lá Fhéile Bríde than with the ISMO presentations. So as Angela mentioned, we got 55. We actually got 57. We found 2 more in the zip file. So 57 abstracts were submitted. And this year, for the first year, we had to institute a more competitive process because we only had time and space to have about 20 oral presentations. But I think over time, that will actually increase the quality of the presentations that you're going to hear. So myself, Michael McCarthy, Liam Grogan and Miriam O'Connor independently scored those 57 abstracts, and then the top 20 were invited to give an oral presentation this morning, and the remainder have poster presentations which we'll judge during the lunch break. So many thanks for coming. We have a tight schedule, and I'm going to definitely keep everybody to time. When you're up here presenting, you'll see a large screen in front of you. You have 4 minutes to present and the screen will turn red. So you really have to wrap it up then, and we have a minute or 2 for questions between each speaker. Can I ask if there are any medical oncology consultants in the audience? You are an adjudicator this morning, And we need to give you a scoring sheet. So if you did not get a scoring sheet, please put up your hand so that Ken can give you one. Fantastic. Great. Okay, without further ado, keep those hands up till Ken finds everyone for a scoring sheet. And we're going to go ahead with the first presentation this morning. Can I invite Gavin Dowling to the stage? He's going to talk about cyclin-dependent kinase 12 as a potential therapeutic target in HER2-positive breast cancer.
Hi, good morning everyone. My name is Gavin and today I'm presenting on CDK12 as a therapeutic target in HER2-positive breast cancer. So CDK12 is located in close proximity to HER2 on chromosome 17 and is frequently upregulated in HER2-positive breast cancer. It's traditionally known for its role in DNA damage repair. However, there's increasing evidence that it can actually drive trastuzumab resistance, and some large retrospective studies have shown it to be associated with inferior survival outcomes on anti-HER2 therapy. CDK12 inhibitors are in development, with some in the clinical trial stages. So it became a target of interest for us based on the results of 2 clinical trials carried out by our research group. The first was the PANTHER study, which investigated copanlisib and trastuzumab in patients with advanced HER2-positive disease. And in this cohort, an increase in CDK12 copy number was observed in 2 patients at the time of progression. Second was the neoadjuvant TCHL trial, in which whole exome sequencing of the patient's pretreatment tumor biopsy showed a statistically significant higher total copy number of CDK12 in patients who went on to have residual disease versus those who achieved a pathological complete response. So we therefore aim to investigate CDK12 and its role in trastuzumab resistance, and to investigate the efficacy of CDK12 inhibition in combination with anti-HER2 therapy. So we did this by first getting a variety of CDK12 inhibitors and investigating them in a panel of HER2-positive breast cancer cell lines, including those with acquired resistance to trastuzumab. Interestingly, we found that the cell lines with acquired resistance to trastuzumab were actually more sensitive to the inhibitors than their parental counterpart. And we decided to focus in on dinaciclib, as it's a multi-CDK inhibitor which is at its furthest stage of development, having been used in clinical trials. So next we looked at combining trastuzumab with a variety of concentrations of dinaciclib, and here we can see the parental cell line in blue and the trastuzumab-resistant cell line in red. And again, we found that the trastuzumab-resistant cell line was more sensitive to dinaciclib than its parental counterpart, particularly at the lower doses. And again, we validated this further in a second cell line, the BT474s, which are also HER2 positive. And again, we found much greater sensitivity in the trastuzumab-resistant cell line than the parentals. So we then moved on to investigate the role of dinaciclib treatment and the effect of it at a protein level using Western blot analysis. So if we look at the densitometry results here, on the left we can see that the effect of dinaciclib treatment on the parental cell line was minimal. However, the effect on the trastuzumab-resistant cell line was significant, causing a significantly reduced expression of phospho-AKT, CDK12, and HER2 in the cells after 24 hours of treatment with dinaciclib. So we are currently validating these findings in vivo using CAM models, and we have also sent off RNA and DNA for sequencing to hopefully further elucidate the mechanism behind this increased vulnerability. So in conclusion, CDK12 is a pivotal player in HER2-positive breast cancer progression and a potential therapeutic target. The enhanced sensitivity of the trastuzumab-resistant cell lines to dinaciclib suggests a collateral vulnerability and provide a rationale for combining CDK12 inhibition with anti-HER2 therapy to overcome this resistance. Thank you.
Any questions for Gavin?
Microphone.
Oh, microphone. Any questions for Gavin? Can I ask, what part of this work did you do yourself? Are those your Western blots?
Everything.
Fantastic. That's what we want to hear. I'd like actually if people when they're presented could also let us know what they are or what stage of their career they're at. That would be helpful if you can just tell us if you're an SHO or a route or an SBR, etc. Any other questions for Gavin? So you're going to Roisin?
And what's really nice, do you have any information in preclinical studies that include pertuzumab, which would be the current standard of care?
Yeah, I don't. We do have some models in the lab which have acquired resistance to trastuzumab and pertuzumab, so we will hopefully investigate them next as well. Yeah.
Great. Thank you very much, Catherine. Next, we have Dermot McMorrow. He's going to discuss the clinical impact of anti-EGFR re-challenge in RAS-BRAF wild-type metastatic colorectal cancer.
Good morning. Dermot McMurrow is my name. I am a senior health officer in the Mater Hospital. This morning I'm going to be talking about the clinical impact of an anti-EGFR re-challenge in RAS-BRAF wild-type metastatic colorectal cancer. Anti-EGFR agents such as cetuximab and panitumumab are a standard of care treatment option available in RAS-BRAF metastatic and colorectal cancer. Response rates for patients who are re-challenged after a period of treatment are between 8 and 32%, with progression-free and overall survival between 2 and 6 and 10 and 17 months, respectively. Selecting patients based on the absence of known resistant mechanisms has been associated with improved response rates. Primary goal of this analysis was to assess the clinical impact of anti-EGFR re-challenge in an Irish setting. So what we did was we looked at all patients who had received a anti-EGFR agent in an Irish centre over the last 10 years. We defined re-challenge as a period of at least 60 days off a targeted therapy. The data was collected from the CATO database and initial processing through Python and subsequent analysis through R. We defined duration of therapy as from the start of the re-challenge to the end of therapy given. And then overall survival was defined as start of the re-challenge again to the date of last follow-up. All in all, we had 82 patients in this cohort. Average age of diagnosis was 56. 56% of these were male. You can see the majority received cetuximab and majority again were left-sided tumours. 24 patients fulfilled the criteria for this re-challenge. So, as you can see from the swimmer's plot, our gold is essentially our first treatment, our red colour is our gap, and blue is our re-challenge period. At time of cutoff, 16 of the 24 were still alive and on therapy. The median gap between therapies was 243 days, and the median duration of follow-up was 34 months. Median duration of time on therapy was 3.4 months, and the median overall survival was 9.2 months. So how does this compare with the options we have available to us? When we compare it to large trials in this area for this cohort, so this is the refractory metastatic RAS-BRAF wild-type metastatic colorectal cancer. If we look at the correct and Sunlight trials, we seem to be performing a bit better, and we're in or around where FRESCO-2 is. So these trials, they looked at regorafenib, fruquintinib, and bevacizumab. So I think that this overall shows that re-challenge with an anti-EGFR agent is a viable therapeutic option for this cohort. And there's a lot more we can do in this area. So what we hope to do next is essentially we want to look at ctDNA assays for this cohort before and after they are challenged and then re-challenged with an anti-EGFR agent, looking at the change in targeted mutations. We have applied and recently secured funding for this next stage of the project, and we are looking for collaborators. As you can see, this 82 over 10 years was relatively modest numbers, so we are looking to get other centres involved. At this stage, I take the opportunity to thank everyone that was involved in the project, specifically Darren Cowser and Niamh Hoban and Professor John McCaffrey. Thank you very much.
Any questions for Dermot? Did I see there that the median time to treatment failure was 3.something months, 3.4 months? Yep. So I wonder about assessment bias. How often were these patients having CAT scans? Do you know?
In and around 3 months.
Funny.
Yes.
Well spotted. but I did see from your survey spot there were some very long
were.
responders. Yeah.
Yes.
So really interesting to look at those.
Yeah, absolutely. And unfortunately, we were hoping for a larger sample size to kind of really dig into these. But when you're looking at one or two cases that were almost outliers, it's hard to get any meaningful messages from that.
Yeah. ctDNA would be interesting. Yes. Any other questions? All right, we'll move on. Many thanks. So next we have Abdullah Mohammed. He's coming from Waterford and talking about the effect of COVID-19 on incidence of de novo and relapse breast cancer, a 10-year review and medical oncologist experience.
Hi, this is Abdullah Mohammed, coming from University Hospital of Shuwatabkor. I'm going to present the impact of COVID-19 to the incidence of metastatic breast cancer. And that is 10 years, that is 10 years review from 2015 until 2024. So we have found previously that the COVID-19 disrupted the healthcare system, including the oncology service, and this is affected the presentation and the diagnosis and the time of treatment. And this is actually this is systematic review of approximately 80% of breast cancer cases seen in University Hospital Waterford. We look at these objectives here. The primary endpoint is just to compare the incidence of metastatic breast cancer subdivided by de novo breast cancer and relapse breast cancer from 2015 to 2019, and this is Group A, and from 2020 to 2024, and this is Group B. And we have secondary endpoints to look at the different subtypes of breast cancer and to see the relapse of breast cancer. Is the relapse is early or late, or the relapse is late. We have collected the method from the consultant sheets, including the clinics and MDTs and laboratory systems, and we stratified the data according to the number of breast cancer who attended and the number of breast cancer of metastatic disease that is divided into de novo and relapse breast cancer, and we look at that as I mentioned, Group A and Group B. We have these results. You see the increase in total number of breast cancer from 2015 to 2019, and that is 934. But if you look at the Group B, when at the end of 2024, this is increased to 1,102, and the number of metastatic breast cancers that represented about 10% is actually as well increased. You see here, this is the total cases of metastatic breast cancer that represent around 10%, and that is subdivided to de novo metastatic relapse breast cancer is actually increasing number. We see here in 2015 to 2019 is 46, and this number increased again to 75 from 2020 to 2024. And here the relapse breast cancer as well, there is increase as well from 31 to 51, and that represents 40% from this number, and that's 44 from this number. Here, if you look at Group B and Group A, in post de novo relapse, they increase. You have 5% to 6.8% from Group A to Group B. And this is here also for relapse breast cancer. There is increase here from 2.9% to 5.3%. So but now if you look at the secondary endpoint perspective, we have documented the increase as well in triple negative states, and that is early stage, or if you look at the metastatic disease, there is increase in triple negative as well. And we found that in Group B, the time for relapse is reduced by 2 years. So we have concluded but COVID-19 were reporting increase in all stages of breast cancer, and in metastatic group we have increase also in de novo relapse metastatic breast cancer. But we want to look at the different institutions to see.
Thank you. Any more questions? Right, ahead, Conk.
And thank you. Nice work. I was just wondering, did you do any statistical analysis on these figures to see if they're statistically significant?
Yes, I have done statistical analysis, and the confidence interval was high, was 95.95%, and the probability is less than 0.001.
And what test did you use?
Sorry?
What test did you use?
I used partial median. Yeah, but partial median is a time of relapse. If you look at the relapse, the time of relapse of breast cancer, I divide that as median, and then after that I calculate the probability.
Were you surprised by the results?
Yes, it seems that to be surprised that the rate of triple negative breast cancer is increased, and COVID-19 is actually could lead to decrease in the time of relapse of breast cancer from 2020 to 2024.
Okay. And we're doing so much better, we think, with our adjuvant therapies. We've approved a lot of new approved drugs in that setting, and yet the percentage of relapse cases went up as opposed to de novo mets.
Yes, with de novo mets, and this is actually from 2020 to 2024. We noticed that we are thinking that could be related to some sort of tumor biology that affected by COVID.
Okay.
By COVID. Think about it.
Any other questions? We leave it there. Thank you.
Oh, that goes.
I'd like to invite Liam Moran next. He's going to ask, are routine steroids required to prevent significant nausea in patients receiving low-dose cisplatin? A retrospective chart review. Okay.
Good morning, everyone. Liam Moran is my name, and I'm one of the oncology SPRs in University Hospital Galway. I'm going to be talking to you today about the necessity of routine steroids after low-dose cisplatin. So cisplatin is a very common chemotherapy regime. We've been very familiar with it for its use for decades, and NCCP does classify it as a highly emetogenic chemotherapy regime, and NCCP and ISMO recommend high-dose dexamethasone be prescribed for up to 4 days after treatment, and this could total 216 milligrams of dexamethasone, or the equivalent of 1,500 milligrams of prednisolone for patients. We're all very familiar with the side effects of high-dose steroids, but in particularly, we have to pay attention to the immunocompromisation aspect of this with concurrent chemotherapy such as PCP. And of course, a lot of our patients also have concomitant comorbidities as well as other risk factors which predispose to this. So the intentions of this review were that in 2020, University Hospital Galway reviewed its local policy on whether routine regular steroids were necessary after weekly cisplatin, and at that time changed the routine steroids to long-acting 5-HT3 and NK1 antagonists, and these were given on day 1. Previous to this, ESMO did suggest that dexamethasone-sparing antiemetic regimes can be considered in some instances, and we reviewed as to whether these had negatively impacted on patients' treatments. So this is a retrospective chart review, and we focused on patient outcomes and whether patients receiving low-dose cisplatin concurrently with chemo and radiotherapy between 2022 and 2024. The routine antiemetics used were Akynzeo, given on day 1, and dexamethasone 12 milligrams IV, given on day 1 only. Patients were also given Cyclizine to take at home. Data was collected from pre-treatment nursing assessment e-records, and nausea was recorded and graded by CTC-AE version 5, and there was also recording of PRN antiemetic use, and we also looked at whether there was interruptions or omissions of treatment due to nausea, and whether there's any dose modifications or early terminations. Overall, 85 patients were included, and of these, 23 or 27% reported grade 1 to 2 nausea, and a high number, 62 or 73%, reported no nausea at all. And thankfully, no evidence of grade 3 nausea was found. In those who did report nausea, antiemetics were not escalated, and routine take-home steroids were continued to be omitted. Cisplatin was not omitted or modified for the reasons of nausea, and the majority of patients completed 5 to 6 cycles. So in conclusion, the omission of steroids does not appear to negatively impact on patients' symptoms or treatments, but we do acknowledge that this is limited by the fact that it's a retrospective chart review and that there is the open door and the role for future investigations. A randomized controlled trial is being thought of in the department. And we also do acknowledge that Akynzeo is significantly more expensive than dexamethasone, and that given that this was a retrospective review and nausea was not the sole focus of the nursing assessments at the time, some data may have been lost or misrecorded. We also acknowledge that dexamethasone may have prevented other toxicities such as fatigue, and only treatment changes secondary to nausea were recorded. The reported levels of nausea were much less in this trial than the original studies. There was a higher number of grade 0, 73% versus 16%, and no grades greater than 3. Omission of steroids could reduce toxicities from their protracted use, and ISMO has recently published a meta-analysis suggesting that steroids are non-inferior, or steroid-sparing regimes are non-inferior in highly emetogenic AC-based regimes and in moderate emetogenic regimes. And so more research could be used on other highly emetogenic regimes. We hope that this will impact national guidance on the safety of omitting high-dose steroids for low-dose cisplatin. These are my acknowledgements. These are my citations. And thank you.
Any questions for Liam? Let's see what we come up with. I'm not familiar with Kinzio. Is it a one day, one drug?
Yeah,
or
day one capsule.
Day regimen.
Yeah.
It's not like aprepitant to amend. Okay. No, very interesting work, and certainly we found the steroid sparing with AC has gone really well. Obviously, we're using olanzapine in that setting as an adjunct to anti-nausea. Cliona, thank you.
How does the price of Akynzeo compare to aprepitant plus ondansetron?
So I didn't get a value from our local pharmacy, but I did see that nationally Akynzeo costs $700 for one dose, whereas 100 tablets of dexamethasone costs $20. So it is significantly cheaper in that aspect.
Well, compared to aprepitant.
Oh, sorry, aprepitant, sorry. I'm not actually sure about the value of the price of aprepitant.
Is it a high-tech scheme drug?
No, it's dispensed by pharmacy. So the day ward would give it before they give the cisplatin. Pharmacy would dispense it with the chemo.
So it's coming out of the hospital drug budget.
Yeah.
Okay, thank you, Liam. Next, we have Raisa Berzina, who's talking about quantifying the public-private reimbursement gap, a retrospective analysis of 154 EMA-approved anti-cancer drugs in Ireland's healthcare system.
Good morning, everyone. Sorry. I think Good morning, everyone. My name is Raisa Berzina. I'm one of the SHOs in Galway University Hospital, and today I'm presenting this study titled Quantifying the Public-Private Reimbursement Gap, which was a retrospective analysis of 154 EMA-approved drugs for cancer. So within the last 2 years, we have seen a growing divide between access to these EMA-approved cancer therapies among the public and private patients. That's because the private patients have, in principle, access to all approved EMA drugs, while public patients, they need to wait for this HSE reimbursement process that is very lengthy. It can take up to 2 to 3 years. So we collected our data from the EMA website on 154 anti-cancer drugs for solid cancers from 2013 to 2024, and we cross-referenced the reimbursement status of each drug through the NCCP. We further classified the costs into low and high cost. So here are our key results. We see that 55% of those 154 drugs are reimbursed to public patients. However, 40% are not. When we classify further reimbursement by cost, we see that 70% of reimbursed drugs are low cost, and we see that almost 100% of the not reimbursed drugs are high cost. So here we see the drug class per group, and we see that on the reimbursement drugs, the two majority groups are chemotherapies and target therapies, whereas for unreimbursed drugs, those are targeted therapies and immunotherapies, which are more expensive, obviously. Here's a snapshot from 2020 to 2024, the drugs that are approved but are awaiting reimbursement. So it's not surprising to see that last year we still have 12 drugs awaiting reimbursement. Here is the leading cancer groups still awaiting the drug reimbursement. And on the top, we see non-small cell lung cancer, and coming next, breast cancers, melanoma, and renal cell cancer. So these are the most affected drug groups in Ireland caused by the reimbursement delay. So from this study, we conclude that there is significant disparities we can see with the numbers. So 41% of those approved EMA drugs are awaiting reimbursement to public patients. And obviously, cost is a big factor for decisions for reimbursements. And we would like to see some policy change for public patients. So all patients, independently from their insurance status, can receive those effective treatments. Thank you.
Just pop up your hands if you have questions. Thank you. It's very sobering findings in your study. It's been troubling all of us for quite some time. I don't expect you to have all the answers, but do you have any thoughts on what we can do about this problem?
It was just surprising to see that Ireland ranks, one of the last countries with these drugs are waiting to be reimbursed, and we see, Germany as the first, and other Western countries. I think that probably the size of the countries is one of the factors. So I think that the reimbursement process in itself is a complicated one, and we see costs is a major factor, but I think this is something to be organized between the pharmaceutical companies and the organization in Ireland that takes care of these, to get those drugs reimbursed to AGC.
Any questions, Patrick?
Thanks very much. It's one issue. Consider looking at how many of the drugs have been associated with an overall survival benefit, or how many are in areas of really unmet need. Obviously, you've brought a lot of breast cancer, lung cancer drugs, but caught my eye that you have 3 in glioma, where there clearly are not many effective therapies.
No, we haven't looked into that. This is something that we can prospectively look at it.
Angela?
Thank you. Just wondering, did you include an analysis on the manufacturers of the drugs to see if there's any scope to potentially, lobby on behalf of a wide group of drugs per manufacturer?
That's a very interesting question. Unfortunately, so we didn't see the data provided by the EMA on that.
Okay, thank you very much.
You. Thanks so much.
Next up, Rachel's going to present a trial in progress. It's a prospective translational study investigating the association of gut microbiome diversity with pathological complete response after neoadjuvant treatment in early stage breast, rectal, and esophageal cancer.
So my name is Rachel Clark. I'm medical oncology SPR working in Beaumont RCSI Cancer Centre, and I'm presenting some early results of our prospective translational study looking at outcomes in relation to the gut microbiome diversity in early stage breast and GI cancers. The gut microbiome is something that has been that has increasing interest over recent years, and its impact on cancer and outcomes is no different. In relation to the gut health, diversity is thought to be key. In this small pilot study carried out on triple-negative breast cancer patients, they saw a correlation between gut microbiome diversity and pathological complete response rates in patients undergoing neoadjuvant treatment. Just to look at our study design, we included patients with early stage breast, rectal and gastroesophageal cancers. They had fecal analysis completed prior to commencing neoadjuvant therapy, at the end of therapy, and 6 months post completion of neoadjuvant treatment. The primary endpoint of the study was to assess an association between gut microbiome diversity and pathological complete response. Some secondary endpoints were looking at quantification of cell-free DNA and longitudinal change in gut microbiome diversity. So far, we have consented 32 patients for the study. 11 patients were excluded due to failure to submit an initial sample. Of these patients, there were 8 patients included were breast cancer patients, 9 were rectal, and 4 patients had gastroesophageal cancers. 13 patients so far have undergone resection. 1 rectal cancer patient is being managed on a watch and wait strategy. And 1 patient had an open and closed procedure due to failure to respond to neoadjuvant therapy. 5 patients so far have had a pathological complete response. Looking at some of the results of cell-free DNA, these were serial samples taken pre and post neoadjuvant therapy. We can see for the 4 patients at the left of the slide, there was no response to neoadjuvant. No pathological response, and these patients all had a rise in their cell-free DNA at the end of treatment. These 2 patients, interestingly, who had a reduction in cell-free DNA at the end of treatment, did have pathological complete response. Both were breast cancer patients. Looking at the trends of gut microbiome diversity serially over time, we can see that there's a trend towards a reduction in the diversity of the samples at the end of neoadjuvant therapy, and it appears to return to normal or almost normal at the 6 months following treatment. One outlier of this is a patient who had obviously less diverse microbiome. This patient is a patient who had the open and closed procedure and had no response to neoadjuvant therapy. And just to look at some of the 15 most abundant bacteria, as you can see in these serial samples, the most prominent bacteria change over time. This is maybe more pronounced in the esophageal and the rectal cancer patients, where we can see a clear increase in some different bacterias. Such as this, the Escherichia and Shigella in the purple and maroon have increased over time. And the fecal bacterium and Ruminococcus in this sample increased over time. And finally, the Streptococcus in this last sample increased over time. So in conclusion, there are some indications of some early trends: a decline in cell-free DNA in patients with pathological complete response. The gut microbiome diversity appears to decline on chemotherapy but recover 6 months post-treatment. And we see that there are changes to the most abundant bacteria species during neoadjuvant therapy. The recruitment to this trial is ongoing, and I'd like to thank all of our collaborators.
Can I ask what bit of this trial you're doing yourself?
Consenting and collecting samples.
Are you also capturing antibiotic use?
Yeah, so antibiotic use kind of is thought to be a surrogate marker for gut microbacteria diversity. So we are now collecting that data, and also PPI use.
Great. Any questions, Rashim? I'll wait for you.
If you were to find after the study was complete that there was a specific result around maybe a correlation with the microbial diversity and PCR, what would your next step be? How would you intervene to improve outcomes?
I guess that's a difficult question, because I think the research really probably isn't there just yet. That there are trials ongoing looking at maybe alterations to diet, whether there are some bacteria that have a higher association with like colorectal cancer, and they have an impact on outcomes as well. And so now that that has been found, there are more trials looking into what we can do about it, how we can prevent it, and change the outcomes for patients.
Nice one, Rachel. Can I ask, for the breast cancer patients with their neoadjuvant therapy, they will likely be having immunotherapy or anti-HER2 as well, compared to the other cohorts, which are mostly chemo in the neoadjuvant setting.
Yeah.
What do you think that would impact on your findings?
Yeah, so I think gut microbiome, the gut microbiome has been studied mostly in melanoma and patients on immunotherapy. I think this cohort of patients is going to be very heterogeneous. They're all on different treatments. A lot of the GI cancers are undergoing radiation as well, which I think will impact, I think it will be difficult with this heterogeneous group to look at this kind of subgroups.
Thank you. Great, Rachel.
Thank you.
So unfortunately, speaker number 7 is unavailable to make it today. So just draw a line through that on your scoring sheets, please, so we've no confusion. So we're going to proceed with abstract number 8. I would ask Divya to come down. She's going to speak on acceleration in the rate of practice-changing publications guiding systemic treatment of advanced cancer, a review of landmark studies between 1994 and 2023.
Hi everyone, Divya is my name. I'm one of the associates in Galway University Hospital. I'm presenting this paper today called Acceleration in the Rate of Practice-Changing Publications, Guiding Systematic Treatments of Advanced Cancer, a review of landmark trials between 1994 to 2023. Systemic oncology treatment is rapidly changing and increasingly targeted. The rate of their practice-changing publications have been accelerating and they're becoming increasingly biomarker or molecular targeted. Aim of the study is to characterize the timeline and trend of practice-changing publications in systemic treatments of advanced or metastatic prostate, lung, colon, and breast cancer. So we use the NCCN guidelines to look at the current systemic treatment of advanced lung, prostate, colon, and breast cancer. We identified the landmark trials that led to the approval of treatments in the last 30 years. All treatments recommended with the supporting trial from the years 1994 to 2023 were included, and the two groups, 1994 to 2008 and 2009 to 2023, were analysed as two separate groups. That's just dividing them to 15 years and 15 years. Treatments were also looked at as whether or not it was applicable to an undifferentiated or specific subpopulation based on NCCN guidelines. So your undifferentiated group is predominantly cytotoxic chemotherapies, while the specific subpopulation would include your TKIs, your ADCs, and immunotherapies. Coming into the results, between the years of 1994 to 2008, 91 practice-changing publications were identified. And between the years of 2009 to 2023, 187 practice-changing publications were identified. This trend was consistent across all cancer subtypes. Now, comparing between the two groups, between the 1994 and 2008, 95.6% of the studies were applicable to a general population, and only 4.4% of studies were applicable to a selected subpopulation, whereas in the group of 2009 to 2023, 63.2% of the studies were for selected subpopulations, whereas only 36.8% of the studies were applicable to a general population. The treatment landscape of oncology is changing. There is accelerated research, there is breakthrough therapies, and this has led to new standard of care treatment options for patients. Increasingly, these publications are more focused on molecular or biomarker-based directed subpopulations. While these trends are welcoming, these tend to be higher cost versus your classic cytotoxic chemotherapies. Funding these drugs, in addition to funding the requisite biomarker testing, is a major challenge in public setting. For newly EMA-approved anti-cancer drugs, Ireland has a two-tiered reimbursement system, public versus private. This is partly driven by an increasing rate of regulatory approval of high-cost anti-cancer drugs. Highlighting these trajectories is important in public policy decision-making. There's a need to address the accelerating rate of regulatory approvals, as well as higher costs associated with these today and into the future. Thank you.
Yes.
Any questions for Divya? Can you just run by me again how you defined a practice-changing publication?
So we looked at the current treatment recommendations in NCCN guidelines for the 4 cancers. Then we identified the trial that led to the approval of the treatment. And then we got the years that the trials were published.
Okay. We can see the thrust of interest coming from the Galway crew doing your research together.
What program did you use to bit? What programs do you use for analysing trials?
For collating the data.
So we collected that as an Excel spreadsheet and they made the graphs based on the data information from the spreadsheet, yeah.
Right.
Great. Thank you, Julia. Now we have Ruth Hutch, who's going to discuss characterising the genomic landscape of anaplastic thyroid cancer and integrated analysis.
Good morning. Thank you to the organisers for inviting me to speak. I'd like to talk about our project. There was a slight name change, so apologies about that. Insights into rare cancers, and in particular characterising the genomic landscape of anaplastic thyroid cancer. Anaplastic thyroid cancer is very rare and frequently lethal cancer. It occurs in about 2% of thyroid cancers, and the median overall survival is about 2 to 10 months. Recent advances in precision medicine have highlighted the need for identifying actionable mutations within rare cancers in order to improve outcomes within our patient populations. We looked at leveraging 2 different data sets in order to characterise the genomic landscape of this rare malignancy. So we used the AACR Project Genie, and this is the largest genomic database publicly available. And by using that, we were able to identify a significant amount of patients, and then we were able to drill down into the mutations, fusions and alterations within anaplastic thyroid cancer. We then retrospectively analysed our own data set within the James's population over an 8-year period. And then we compared the 2 data sets in order to identify frequent mutations that were seen. Within the AACR database, we were able to identify 324 samples among 311 patients. Anaplastic thyroid cancer was seen in less than 1% of cancers. The median age was 67, and the patient characteristics are seen here. So obviously this is a very busy slide, but it just highlights the sheer amount of mutations that were seen in this patient population. And interestingly, somatic mutations were seen in 100% of samples, and the highest frequency was seen within some of the known cancer genes, and I've highlighted some of these here. And again, the actionable alterations and variants that we're seeing within some of the common genes that we're aware of. And then within our own cohort, we again, the patient characteristics were very similar between the 2 cohorts. We identified 24 samples, and again, we saw, similarly to the AACR database, that there was a significant amount of alterations, 66% within our patient cohort. And again, the frequent mutations that we saw were within known actionable mutations and within the same variants that we saw within the AACR database. So what does that mean for our patients? So anaplastic thyroid cancer is a very rare cancer. We have limited therapeutic options, and our data comparing the 2 data sets confirms that there's a high burden of somatic mutations in this patient population. It highlights the critical need to carry out NGS testing in order to identify patients that will benefit from these therapeutic agents. And I think for an Irish population, it highlights the need to have NGS for our Irish patients to improve outcomes. Thank you.
Michael?
Great presentation. Great presentation. I was just wondering, who should pay for the sequencing testing, and how could we go about organising?
Yeah, I think that's a difficult question. It's a question I ask myself. I was under the impression some of them are reimbursed, but unfortunately they're not. I think it's these type of studies into rare cancers, but also common cancers, and it's important for us to lobby. It's important for us to, lobby to some of the patient groups, but also to the government that these should be paid for. But I mean, it's important. We don't have therapeutic options for a lot of these cancers, and as well as some of the common cancers as well.
Thanks so much for that talk. I thought it was really interesting and really important to understand these rare cancers. I thought it was super that you were able to look at this through CBioPortal. Can I ask, did you have an opportunity to use CBioPortal?
I did. Thankfully, Dr. Coleman has helped me to use the portal. It took me quite a while, but it's a fantastic resource, and I think it's something that we all should
You want
get
to
used to.
tell your colleagues a little bit about what it is and what it does?
So it's the largest database publicly available. You can log on and you can set up your own account. It's taken from 15 cancer centers in the US. But again, it gives you so much information. You can click into different studies in multiple different in all cancers really. There's you can click into all the studies that they did, and then you can look down into the different mutations and genes. You can look at the characteristics. There's a lot more information that I haven't yet got a handle on at all, but there's multiple YouTube videos that are available. So,
and are you aware of any other databases similar to the CBioPortal?
So there's different databases in the US, but actually there's one in Europe at the moment, and we're involved in one in Ireland that's being funded by the EU, and they're trying to collate a similar database within Europe, and I'm sure there's other ones as well.
I think this is a great project to highlight that along with the political skill, it's important to develop new scientific skill. And I think for our trainees to understand how to use CBioPortal, OncoKB, My Cancer Genome is probably, a key skill for the future of the specialty. So thanks for highlighting that.
Thank you.
Next, we have Cormac O'Flynn, who's giving us a retrospective review of peritoneal portacounts for malignant ascites, a potential alternative.
Thank you. Good morning, everyone. My name is Cormac. I'm a first-year SBR in Waterford, and I'll be talking about peritoneal portacounts today. So, a bit of background on the topic. Malignant ascites is a common and debilitating complication of advanced cancer that can severely impact patients' quality of life. Large volume paracentesis may be performed to relieve discomfort. However, this procedure may be frequently required in rapidly reaccumulating ascites. Tunneled Pleurex peritoneal catheters may be used as a more long-term solution. However, these can be left in situ and be used for drainage in hospital or in the community. Peritoneal portacounts then are a potential alternative to this. You'll all be familiar with vascular portacounts, which are widely used in oncology patients. And as far back as 2001, studies suggested that these ports could be repurposed as peritoneal ports for the drainage of recurrent ascites, and subsequent studies have shown that peritoneal ports can be a safe and effective management strategy. Theoretically, these ports should have a number of advantages over tunnel drains. Potentially, they have less risk of infection as there's no external drainage component when not in use. There's less risk of dislodgement, and cosmetically, they're more discreet for patients. And in fact, insertion of these abdominal ports has been common practice in Waterford for a number of years now. So we conducted a retrospective review of peritoneal ports inserted from January 2019 to September 2024. 55 ports were inserted in this timeframe. The average age was 67 years. GI and hepatobiliary malignancies made up the vast majority, followed by gynecological and breast. 85% of patients had stage 4 disease, and the other 15% had stage 3 gynecological malignancies, and the majority of these had platinum refractory disease. 87% of patients had one or more lines of therapy prior to port insertion, 33% had 3 or more lines of therapy, and 13% were treatment naive. The graph here shows the duration of time between insertion and death in orange, and the duration in situ for each patient in blue. And the average time between portacath insertion and death was 61 days, and the shortest being 3 days. This was a sudden, unexpected death unrelated to the port insertion. And the longest was 358 days. However, in this case, the patient did develop a port site infection and had to have the port removed and had a new one inserted at a later date. And the average time portacath remained in situ, therefore, was a bit lower at 50 days, and the longest was 200 days. All portacath insertions were successful with no immediate complications. 7 patients developed complications, so 4 port site infections, 1 peritonitis, 1 overlying seroma, and 1 port dehiscence or skin breakdown. 6 of the 7 ports which developed complications required removal. In conclusion, peritoneal ports are a viable option for the management of recurrent malignant ascites. Appropriately selected patients can derive a long duration of benefit. The complication rate of 13% and infection rate of 9% are relatively low and comparable to the published data. I would say research in this area is lacking, and in fact, our cohort of 55 patients was one of the largest cohorts I saw. Future directions of study should include studies comparing portacaths, pleurex strains, and large volume paracentesis head to head. And we'd like to look at assessment of symptom control and quality of life measurements in patients going forward. These are my references and closures. That's it.
So can the patients be educated on draining this themselves? Do they access it at home themselves or with family?
So it requires a gripper needle to be attached. So either like the community IT can attach that, and then it's just attaching a drainage bag which you can clamp and unclamp. So they can go home with a drainage bag attached and clamp and unclamp it, or it can be accessed intermittently for drainage on any given day. Yeah.
And are the supplies covered free of charge for the patients?
So it would be funded through community interventional team, yeah.
And have you found it acceptable to patients?
Yeah, patients seem to like it. I guess they don't know the alternative, I guess, of the strain with a kind of external drainage component. So,
wondering, does it drain out very slowly?
It does drain a bit slower because they don't use the Pleurex kind of vacuum bottles. But it seems to be quite manageable, yeah.
Any other question, Michael?
Just agree with you. I was just wondering, where does it sit, the portacath? It must be over the ribs or something like that?
No. So they actually do it overlying this subcut tissue in the abdomen. Only I think we did have one patient, an obese patient, where it was more difficult to access, just because you don't have the firm underlying kind of rib cage. But other than that, there's been no issues. Yeah.
Just a quick question, are they inserted using IR? And if so, is that a limiting factor in relation to access and possibly timing of insertion?
Yeah, so I guess similar to the Pleurex strains, it's inserted by IR. So they're in Waterford, they're great for facilitating them.
Okay, we're all moving forward, person. Thank you. Okay, next we have Finbar Conroy from The Matter speaking on circulating cell-free DNA for colorectal cancer screening.
Thank you very much for the invitation to speak today. I've lost my Matter logo in the top right corner, so I'll just ask you to visualize it as you go. My name is Finbar, one of the oncology regs working in the Matter at the moment. As all of you will know, colorectal cancer remains a significant cause of mortality here in Ireland. Our national screening programme is BALScreen, established in 2012 and utilises 2-yearly FIT or fecal immunochemical testing to decide who to bring to a screening colonoscopy. FIT screening has been shown to improve mortality of CRC, but uptake has been less than expected and is reported as 46.6% in the last report. Today we're going to have a look at an alternative screening method proposed last year and compare it to our current screening. So this cell-free DNA emerged last year in a paper in the New England Journal of Medicine as an alternative screening method, and they described its performance relative to colonoscopy in a population eligible for colorectal cancer screening. This cell-free DNA is DNA fragments that are released by apoptotic or necrotic cells in into the blood circulation and then can be picked up using either next generation sequencing or PCR techniques. So we did a comparative analysis comparing this published data of cell-free DNA and FIT compared to our current BioScreen program, in particular focusing on the performance characteristics. What we found in terms of colorectal cancer detection, cell-free DNA and FIT had similar sensitivity and specificity. However, there was a lower false negative rate and a slightly higher false positive rate for cell-free DNA compared to FIT screening. In terms of BioScreen, they performed 7,913 colonoscopies in the year 2020 to 2021, which was the last report published, with 208 new cancers detected. They reported an interval cancer rate of 3 per 1,000 patients screened at 3 years. In terms of advanced adenoma detection, there was a broad FIT sensitivity range described in meta-analysis in the published data, and the cell-free DNA sensitivity was found to be within this range. BioScreen reported an adenoma detection rate of 58.1%, with high-grade dysplasias in 3.82%. We then thought about what are the factors we needed to consider in relation to this data. As you mentioned, screening uptake has been one of the biggest challenges to BioScreen, and cell-free DNA is often reported as an alternative to increase uptake. Given that this was a screening program, thinking about the identification of these precancerous adenomas is a really important consideration given the known adenoma to carcinoma sequence. Interestingly though, looking at stage 1 and 2 colorectal cancer, there was some reasonable sensitivity for cell-free DNA in picking these up, and it may have a role in the detection of early stage CRC. There has, however, been no cost effectiveness done to date. So in conclusion, there is potential for cell-free DNA in terms of detecting CRC, identifying advanced adenomas as part of a screening program, may be a potential role of cell-free DNA, but this broad FIT sensitivity range makes accurate comparison very limited. The other thing that may play a role with cell-free DNA is to think of it as a complementary tool and whether or not it could fit into the current framework of BioScreen. This test is available commercially in the US, looking at cell-free DNA, and is being marketed at the moment and is FDA approved. But I think to bring this to meaningful clinical practice in Ireland, we certainly need a lot more studies on it. Thank you.
Thank you. I think for anyone who's ever undergone bowel prep, this is definitely a very attractive prospect. Do you know if you are to perform, is there any evidence suggesting that if you perform serial cfDNA on a patient, you might increase your sensitivity and or specificity?
We actually don't have any evidence for that at the moment. There is evidence for that for FIT, that the more repeated testing you do, the more accurate it becomes. But at the moment, there's no evidence for cell-free DNA that it does.
Any other questions? All right, we'll let you go. Thank you. We're at the halfway mark now. So Emma Pounder's here from Limerick. She's going to discuss radical chemoradiotherapy for cervical cancer, introduction of GCIG interlace into an Irish tertiary cancer centre.
Thank you very much for having me today. So my name is Emma Pound. I'm one of the oncology regs at the University Hospital Limerick. And today I'll be presenting radical chemoradiotherapy for cervical cancer, introduction of neoadjuvant interlace into an Irish tertiary cancer centre. So the therapeutic standard for locally advanced cervical cancer is radical platinum-based chemoradiotherapy. The interlace trial demonstrated an 8% 5-year overall survival benefit by adding neoadjuvant chemotherapy. This study evaluates the implementation of the interlace protocol using intensity-modulated radiotherapy into a real-world setting by assessing post-neoadjuvant treatment response, tolerance, treatment delivery, and outcomes. So our patients with locally advanced cervical cancer were offered neoadjuvant treatment as per the interlace protocol with weekly carboplatin and paclitaxel for 6 weeks. We performed an MRI at week 4 to aid in the planning of intensity-modulated radiotherapy.
On completion of their neoadjuvant treatment, they went straight on to concurrent chemoradiotherapy with their intensity modulated radiotherapy and weekly platinum-based treatment for 5 weeks. An MRI was done on completion at this stage prior to their brachytherapy. This is a summary of our patient characteristics, and so far we've recruited 11 patients, and they're fairly standard of the locally advanced cervical cancer population, with majority being squamous and T2B N0 N0. So as mentioned, we did our images at week 4 and then on completion of concurrent chemoradiotherapy, and so far we have 10 patients who've completed their images. On the week 4 scans, of the 10, 9 had a partial response and 1 had progressive disease. On the completion of concurrent chemoradiotherapy images, of our 10 patients, 7 had a partial response and 3 a complete response. So what I've shown here, and hopefully you can see it clearly, is that purple contour is the radiotherapy clinic target volume that was made on her week 4 images. We then superimposed that clinical target volume onto her initial or diagnostic scans. And as you can see that if we were to base that clinical target volume on her initial MRI, it would have had to be a lot larger to encompass this larger or untreated tumour. A lower clinical target volume following neoadjuvant treatment may translate to reduced radiotherapy adverse effects. In the INTERLACE trial, they used a 4-field box radiotherapy, but as mentioned, we're using intensity modulated radiotherapy treatment as per the EMBRACE protocol. This slide highlights that so far we've demonstrated an acceptable toxicity profile. During the neoadjuvant phase, none of our patients had any grade 3 or 4 toxicities. During concurrent chemoradiotherapy, 3 of our patients had grade 3 neutropenia. Importantly, none of our patients had grade 2 or higher peripheral neuropathy, and 2 of our patients had grade 2 hypersensitivity reactions. By adding paclitaxel into what is an alopecia-naive patient population, you're increasing cold cap demands on what are already very busy day wards. 5 of our patients opted for cold cap use, and of those 5, none had alopecia, and the 5 who didn't use a cold cap all experienced alopecia. 9 of our 10 or 90% of our patients completed 4 out of 5 cycles of planned platinum treatment, and all of our patients completed their planned radiotherapy, importantly with no delays between the neoadjuvant and concurrent phase. So obviously our study is in its infancy with ongoing recruitment and follow-up to assess patient outcomes. We're using a novel approach with this intensity modulated radiotherapy with the potential of reduction in radiotherapy adverse effects. So far we've demonstrated a tolerable toxicity profile, and obviously this requires a lot of coordination between all those involved. It's feasible and it's cheap, and it's certainly cheaper than alternative immunotherapy-based approaches that are currently being explored in this disease setting. Thank you.
Questions for Emma? Roshan?
Hi, that was a lovely presentation. Can I ask you, what was the primary objective of the study? What is the primary objective and the sample size for the study?
So the primary objective of the study is really to establish the implementation of this INTERLACE protocol into a real-world setting and see how feasible it is and whether or not it really does interfere or delay the mainstay of treatments of concurrent chemoradiotherapy. That's one of the major concerns of the INTERLACE trial, is that this neoadjuvant treatment may delay or interfere with what is the mainstay of treatment. However, we're optimistic to see how our patients tolerate this treatment.
So what are you measuring then? What is the main measurement in terms of you determining at the end that this is feasible?
So the adverse effect profile, the delay between neoadjuvant and concurrent chemotherapy, the adverse effects experienced not only from the chemotherapy but from the radiotherapy as well, and then overall we'll assess overall response rates.
Right. So I think it's really important to clarify when you're presenting a study like this, what is the primary objective? What is the statistical plan?
Fair enough.
And I think that'll really enhance this because it's a very nice proposal.
Thank you very much.
Thanks very much. Can I just ask you about the patient of progression of disease on neoadjuvant therapy? Do you think, what did you do with that lady? And do you think that had she gone to primary chemoradiation up front, that this may not have occurred, or what you know about the data in that space?
Yeah, so one of our patients did progress on the neoadjuvant treatment. Importantly, she progressed in one local lymph node, so was still suitable for concurrent chemoradiotherapy. Obviously, we had to have a discussion with her explaining the results of her scan. Luckily, on her concurrent chemoradiotherapy, she did have a good response on completion of her treatment. It's hard for us to say whether or not she would have progressed during concurrent chemoradiotherapy, but she did have response on her concurrent chemoradiotherapy, and she's doing quite well.
Michael?
Just how challenging was it to find 66 extra treatment slots in the day wards?
Yeah. That is a real challenge. As we all know, day wards are very busy. However, they are a relatively small patient population. We only have 11 patients so far. It's only 6 weeks of extra weekly slots, and most importantly, they're a potentially curative patient population. So a lot of the time when we're allocating day ward slots, these curative patients need to be kind of highlighted.
Thank you, Emma. Clearly a lot of multidisciplinary effort there. I was impressed you could get MRIs reliably at week 4.
A lot of collaboration, and luckily our radiology department has been very supportive.
Super. Thank you very much.
Thank you very much.
That doesn't look like Kate Coakley. Have we another present? Oh, there's Kate. Super. We have Kate speaking on an evaluation of the utilisation of biosimilar monoclonal antibody drugs in Ireland and barriers to their usage. Thanks, Kate.
So, hi everyone. I'm going to be speaking today about the utilisation of biosimilar monoclonal antibody drugs in Ireland and barriers to their use, which is a project I carried out under the supervision of Professor O'Reilly in Cork University Hospital. I'm currently an SHO in Beaumont. So just looking at the EU pharmaceutical market, you can see there this is measured in billions of dollars, or euros, sorry. And in 2024, biosimilars and biologic drugs represented about 41% of that market. A downward pressure on this market would be biosimilar competition, and it's been estimated that around 56 billion have been saved from the use of biosimilars over the last 10 years. This graph just highlights the spending on cancer drugs globally, measured in billions of US dollars, and you can see that the navy line signifies the growth rate, which is tapered off around 2018, which represents the time when biosimilars entered the oncology drug market. So spending in Irish hospitals has become completely unsustainable. Back in 2013, we were only spending 4.7 million on drugs in acute hospital beds, and in 2023, we were spending 187 million. So biosimilars enter the market when the reference medicine goes off patent, and the EMA approves them to ensure that there's no clinically meaningful differences between them. The biosimilar market in Europe has been maturing since 2006, when the EMA approved the first biosimilar medicine in the world. They have since approved 80 biosimilars and have gained 18 years of experience. There's 3 oncology drugs which have a biosimilar alternative available, and 2 supportive agents. So just looking at rituximab and trastuzumab in this project, they expired in 2013 and 2014, and since then the market has been flooded with biosimilar alternatives. So the aim of this project firstly was to determine the usage specifically of trastuzumab or rituximab and their biosimilar alternatives, and the prices of same in 4 Irish hospitals between 2020 and 2022. And the second part of the project was to identify barriers to their use, by which we distributed 3 novel distinct questionnaires to patients, doctors and medical students, and pharmacists and pharmacy students. So part 1, in terms of results, the utilisation data showed that between the 4 hospitals, the uptake of biosimilar IV trastuzumab ranged from 39 to 100%, and the uptake of rituximab ranged from 0 to 89%. Just having a look at the percentage price decreases. So for Hospital 3, the percentage saving for biosimilar trastuzumab was 73%, and the percentage saving for biosimilar rituximab was 59%. So it's a little bit hard to see this now, my slide's got a bit messed up, but just to price out the rituximab for or MPV for primary CNS lymphoma. The difference between the reference and the biosimilar was actually nearly 11,000 for 5 cycles. And then if you scale this up based on the paper which was published in 2020, looking at the incidence in Ireland, you could potentially save about 160,000 per year. So patients are actually very much in support of biosimilar use. So we surveyed 166 patients and found that they resoundingly would start taking biosimilar if they were offered, and they would also be happy to switch to a biosimilar, which is in line with the 2024 guidance issued by the HSE. Pharmacists are content that biosimilars are at least as safe as a reference medicine, and doctors and medical students also felt that they were safe, but they weren't as content in this. So we actually had 238 pharmacists and pharmacy student responses. Other barriers were lack of biosimilar awareness, reduced trust in EMA approval, inconsistent nomenclature, and no support for pharmacist level substitution. So just to finish off, the importance of this is highlighted by the fact that costly immunotherapy drugs are going to be coming off patent in the next few years, with pembrolizumab patent expiring in 2028. Keytruda was the #1 grossing drug in 2024, and you can see on the right of the slide, it's only going in one direction. So thank you very much.
Brilliant. Any questions for Michael? Question for me from Michael.
Really more a comment that if it seems like it seems great that pembrolizumab is coming up patent, but for these drugs that are high cost, currently the hospitals buy the drugs and they recoup the costs from the centre of HSE. But if your hospital was to switch to a biosimilar that wasn't approved by the ODMS scheme, the cost would presumably be coming out of the hospital budget, and just the way those budgets and the funding streams are not connected is something that will need attention, I think, in the years ahead. But it's a great presentation. Thank you very much.
What percentage response did you have to your survey?
We actually didn't measure the percentage response, unfortunately, just the logistics of handing out the survey in the clinics.
So you don't know the total number you sent out and how many you got back?
I suppose the way I worked it was I was going to the clinics offering people to take the survey if they'd like to take it. So it just doesn't work out that I was able to measure the response rate.
And did you sit down with them and help them answer it, or they answered privately themselves and gave it back to you?
It depended on the person. I would offer if they needed me to go through the survey with them, but I suppose after the first section of the survey where we determined awareness, I provided the EMA definitions of biosimilars and reference medicines so that even someone who didn't know anything about biosimilars would be able to fill out the survey.
And how did you send it out to medical professionals?
So actually, for pharmacists, the PSI, the pharmacy regulator, actually facilitated sending out a mass email to all pharmacists, which really, really helped. You can see we got a really good response from pharmacists. But I think interest of pharmacists in this field as well was really significant.
Great. Thank you very much. And now from St. Vincent's, we have Carolina Weiner-Gorzel. She is discussing the impact of the addition of carboplatin and pembro to neoadjuvant chemotherapy in triple-negative breast cancer, a large retrospective 2-centre real-world study.
Thank you. My name is Carolina Weiner-Gorzel. I'm one of the oncology registrars in St. Vincent. So the title of the project is the impact of the addition of carboplatin and pembrolizumab to neoadjuvant chemotherapy in triple-negative breast cancer. So main aim of this project was to assess the change in neoadjuvant chemotherapy regimens over time and its impact on pathological complete response rate. Design of our study was a retrospective, observational and 2-center study. We used electronic and paper charts between January 2000 and October 2024 in 2 institutions, St. Vincent University Hospital and St. Vincent Private Hospital. The total number of patients included in this study is 378. As you can see from the table on demographic and tumor characteristics, the median age of diagnosis of our cohort was 53 years of age. Majority of our patients had tumor less than 5 centimeters, with over 80% of patients having grade 3 disease. In terms of lymph node status, 63% of patients were lymph node negative. Looking at the estrogen receptor and HER2 immunohistochemistry staining, you can appreciate that 69% of patients were ER negative and 45% of patients were HER2 negative. So looking at our results, from the total cohort, 58% of patients received neoadjuvant chemotherapy, with nearly 69% receiving carboplatin as a part of this treatment and 17.4% receiving pembrolizumab. The most three common regimens in our cohort were TCAC and over 52%, followed by DDACT and Keynote 522, including pembrolizumab. Then we wanted to see the change of this treatment over time, over the 24 years, and we divided that into 3 time periods using 2 specific dates. 2014 was used because in December 2013, CALGB 40603 trial was demonstrated in San Antonio Breast Cancer Meeting, which showed that there is a significant improvement in PAT-CR rates when carboplatin is used to neoadjuvant chemotherapy. And the second date we picked was 2022. This was after approval of pembrolizumab by AMA as a use of neoadjuvant chemotherapy for triple-negative breast cancer patients. Expectedly, as you can appreciate from this graph, we saw a significant improvement in the use of neoadjuvant chemotherapy, carboplatin and pembrolizumab over time, with the green bar being neoadjuvant chemotherapy, purple carboplatin and blue pembrolizumab. And I would like to draw your attention to quite good numbers, particularly after 2022 in our 2 institutions, with neoadjuvant chemotherapy being used by 72%, carboplatin being part of over 83% of those regimens, and pembrolizumab 58.2%. When we looked at PCR rates for our cohort, we saw that when we use neoadjuvant chemotherapy without carboplatin and pembrolizumab, a PCR rate was 16.3. Addition of carboplatin improved that rate to 43%, and addition of pembrolizumab improved this to 65.8%. We were also able to appreciate the significant improvement in PCR rates change with time, nearly tripling, with 22% value of before 2013 to nearly 60% after 2022 in our 2 institutions. So in summary, we demonstrated comprehensive analysis of treatment of triple-negative breast cancer patients. We used increased neoadjuvant chemotherapy, carboplatin and pembrolizumab with time with improved PCR rates. I did not have time to go into that data, but we also looked at a difference in PCR rates between HER2-0 and HER2-low patients, and we saw no difference. And our survival data analysis and statistical data analysis is still ongoing. Thank you so much.
Questions for Carolina? Con?
Nice work. Can you just ask you, given that the use of carboplatin and pembrolizumab is restricted to triple-negative breast cancer, why you included patients with ER-positive disease? Isn't that going to confound your results on PCO rates?
I agree. So the number of ER-positive 10 to 30% was 1.9%, and that can potentially influence the results. So I agree with that. It's a very small number. So for the full analysis, we are still waiting for 10 patients to complete neoadjuvant chemotherapy. So the full analysis, we might consider removing that.
I had the same question. Roisin?
It's really important information, and I'm glad that you're collecting the survival data as well, which is the most important. Are you looking as well at the adverse events? Because
we are definitely looking at the adverse event. As I said, the full analysis will be done after those 10 patients undergo surgery. We didn't notice any significant differences from already known published data and adverse events, particularly on pembrolizumab, with thyroiditis, hepatitis, and colitis being the most important ones. But I don't have the final percentage data.
Might include admission rates as well.
Yeah,
certainly we're seeing huge increase.
Sonia?
Yeah, so nice work. I'd just like to ask, like, with the increasing use of carbo and pembro, would you notice that was there any difference in the patient's ability to complete their neoadjuvant therapy?
Yeah, that is an important question. Actually, a majority of the patients on pembrolizumab, we see that they completed the treatment, but definitely those reductions were a significant part of this this cohort. But again, the final data I don't have to present today.
Great. Thanks, Carolina. Here. Okay, abstract number 15 this morning is going to be presented by Angus McCarthy, utilising a targeted 50-gene NGS panel testing to identify actionable alterations and define the genomic landscape in patients with solid tumours.
Good morning, everyone. My name is Angus McCarthy. I'm an SHO in St. James's. This morning I'll be presenting a snapshot of sequencing utilising a targeted 50-gene next-generation sequencing panel to identify actionable alterations and define the genomic landscape in patients with solid tumours. So I guess genomic profiling through next-generation sequencing has transformed modern cancer care, and it's ushered in an era of precision oncology. However, up until recently, access to NGS in Ireland has been relatively limited, and this has varied between institutions. So what we aimed to do was look at the 50-gene NGS panel, which is currently in use in St. James's, and assess if it has an impact on patient care. We looked back at 3 years of data of all the patients who had had NGS testing in St. James's using this Oncomine panel, and we did retrospective chart reviews to assess the data. We excluded patients who had cancers with their own specific NGS panels. So firstly, to look at, we had 88 patients in total. About 42% of them had an actionable variant detected, and a similar proportion did not. And then there was a small cohort of patients who had an insufficient sample for testing. The most common cancers tested were breast, cholangiocarcinoma, cancer of uncertain primary, thyroid cancer, and adenoid cystic carcinoma. So looking at the variants picked up, I've just included some of the most common variants we've detected. The most common by far was PIK3CA. So PIK3CA encodes a subunit of PI3 kinase. It's commonly mutated in breast cancer. The lollipop plot here at the bottom of the screen just shows some of the common mutations in PIK3CA. One of them being E545K, which we had 6 patients with an E545K mutation, and this has been shown to predict response to alpelisib, which is a direct inhibitor. So does it impact on the treatment of patients? So we certainly showed that it did. So if we look, for example, with our group with the PIK3CA mutations detected, 9 out of the 23 patients had their treatment changed based on the results of their next generation sequencing. And we also showed this for RET and for HER2 as well. So just specifically looking at the mutations. So for patients with PIK3CA, they were able to go on to treatment with alpelisib. As I mentioned, there was 9 patients underwent this treatment. Reasons for not pursuing treatment despite having a positive mutation on the NGS included if they were stable on their current treatment, if they had poor performance status, or they had progression of disease prior to commencement. We also had 3 patients with thyroid cancer who commenced on pralsetinib based on compassionate grounds, and 1 patient with cholangiocarcinoma who received Herceptin. I just want to briefly touch on a case which I suppose exemplifies the utility of NGS. So this was a lady, 53-year-old lady with recurrent hormone-sensitive metastatic breast cancer, had been commenced on ribociclib but progressed with retroperitoneal lymphadenopathy with hydronephrosis, which required stenting. She actually had a PIK3CA hotspot mutation on her NGS. She had a E545K mutation, and in September 2023 commenced on alpelisib. I'm very pleased to say almost 17 months later, she has stable disease on her CT and is doing really, really well. This also just shows how her axillary lymphadenopathy responded to alpelisib as well. Just to conclude, I suppose this has shown that NGS is feasible and that it can impact on patient care and that it can guide treatment decisions. I think in the future, as we move into the world of precision oncology and we have more treatments coming down the line, having access to NGS is really important for our patients. And thank you very much.
Elcon and Min of them.
Thank you. Based on your results, would you recommend next generation sequencing for all patients with metastatic solid tumours or for patients with metastatic breast cancer?
Yeah, that's an interesting point. So obviously the most common patient sample were breast cancer, and all these PIK3CA mutations were in patients with breast cancer. I suppose for the rarer cancers, it's a bit trickier. I mean, we have very, very small numbers, so it's difficult to see. But I mean, even in the case of our patients with thyroid cancer, they did have the RET mutation detected and went on to pralsetinib. So I guess based on the cost, it is a big cost for small numbers. But if it does mean that you do identify some patients that can be commenced on a targeted therapy, I guess it is where it was.
Okay, Minu.
Is this on? Yeah. Very much for the interesting presentation. I have two questions. The first one is, how do you select the patients for NGS? Is it all comers with metastatic disease, or is there certain criteria that you choose on based on clinical status or disease type? And the second one, you mentioned as an FGFR. Which FGFR was that, 2 or 3? Because since there are 5 different FGFR genes.
I'm not sure with the FGFR answer of which one it was. Regarding your question about, sorry, your other question was, can you just repeat the first question? Sorry.
So you have been able to do an NGS on a good few patients, but what was the in-house selection criteria? Is it all sequential metastatic patients who came in during the study period, or is there some criteria?
So as far as I'm aware, it's all patients who had metastatic cancer who were enlisted during the study period. And as I mentioned, it excluded patients who have, specific NGS panels.
Angela, so bringing you down, Mike.
Just very quick. Were the treatment decisions following results, were they made in-house or were they made in conjunction with the molecular tumour board?
As far as I'm aware, they're made in-house by the treating oncologist, yeah.
There is a regular molecular tumour board where cases like this can be discussed. All right, thank you very much.
Thank you.
Joining us now is Orla Fitzpatrick. She's going to discuss another trial in progress at Beaumont, a multi-centre single-arm phase 2 trial of domvanalimab and zimberelimab in patients with non-small cell lung cancer and CNS metastases. Thanks.
I'm going to save a few seconds by not repeating the title as well. So non-small cell lung cancer, as we know, is responsible for a significant proportion of cancer-related mortality, and up to a third of patients will have CNS metastases at presentation. It's also the solid organ malignancy responsible for the highest proportion of patients who will develop CNS metastases during the course of their disease. And the current treatment for this often revolves around surgical resection and radiation. However, the role of systemic treatment is often less well known because these patients are commonly excluded from clinical trials. But we do know that immune checkpoint inhibitors demonstrate intracranial efficacy in the PD-L1 positive population. I do acknowledge that a lot of these trials do include treated or stable CNS metastases. So when we look at landmark papers such as the Keynote 042 trial, single-agent pembrolizumab did lead to an improvement in overall survival, which was clinically meaningful, demonstrating an improvement of 20 months versus 12.2 months compared to chemotherapy. And this led to a significant improvement, including patients with CNS metastases. There was also a landmark paper in 2020 done by Goldberg, which showed an intracranial response rate with single-agent pembrolizumab of up to 25%. This was again demonstrated in the Checkmate 9LA study, which used a combination of nivolumab and ipilimumab, which also led to an improvement in overall survival, including patients with CNS metastases. The combination proposed for this trial of Dom plus Zim has already been shown to be effective in non-small cell lung cancer. And this is a combination of an anti-TIGIT and an anti-PD-1 monoclonal antibody. Domvanalimab is unique in that it has a silent Fc domain, so it doesn't deplete TIGIT-expressing immune cells in the peripheral blood. And the trial that's previously shown this is the ARC-10 trial, and this was a phase 3 trial comparing Dom plus Zim versus doublet chemotherapy in first-line PD-L1 high non-small cell lung cancer, leading to an improvement in overall survival and progression-free survival, which you can see here on the right side of the screen. So the proposal for this trial is a phase 2 study, including patients with histologically or cytologically proven non-small cell lung cancer who have less than 5 CNS metastases. It's going to be a first-line study of patients with ECOG performance status of 0 to 2 who are PD-L1 high with no actionable mutations. Patients will receive domvanalimab at weight-based dosing and zimberelimab at flat dosing every 3 weeks for 4 cycles. And the primary endpoint will be CNS objective response rate using IRANO criteria. Secondary endpoints will include progression-free survival, overall survival, safety, and health-related quality of life. Patients not eligible for this trial will be those who have active autoimmune conditions requiring immunomodulators or escalating doses of steroids, or those who have actionable alterations. When designing the protocol for this study, I used a Simon's optimal two-stage design to plan for the statistical analysis, and this is based on an alternative hypothesis of an objective response rate of 45%. So in summary, we're going to need 33 patients in total. The first stage of this trial will include accruing 17 patients, and if 5 of these achieve an objective response rate, we'll proceed to accrue an additional 13 patients, allowing for a 10% dropout rate. So currently we know that this combination works in non-small cell lung cancer, and we know that PD-1 monotherapy is efficacious in the PD-1 high non-small cell lung cancer population. So the purpose of this trial is to evaluate whether this combination of anti-PD-1 and anti-TIGIT will improve intracranial objective response rates. We plan to roll this out across 2 countries, Ireland and Switzerland, and we aim to accrue over 20 months in total, and we're hoping to start accrual in Q3 of this year. I'd just like to thank Professor Naidu and Professor Curioni-Fontecedro from the Swiss group, as well as Cancer Trials Ireland. Thank you very much.
In Ireland, we struggle to get patients on clinical trials, so we're well under the 10% hope for that. How are you going to get patients to go on to this clinical trial?
So I think we're going to need hospitals to work together. So referrals in and out of hospitals is really important, and I think that there's been an increase in that recently, where we've seen that kind of hospitals are communicating with each other. So even if there were some centres who can't roll out the trial, that they could perhaps refer into other centres to increase this accrual rate. But it is something that really, I suppose, every centre is focusing on at the moment.
And is there some allowance in the protocol to provide compensation for patients to travel or bring a carer with them on the days to try and facilitate that recruitment?
Yeah, so we're still finalising the budget for this at the moment. So it's something that we've asked for, especially if patients are travelling from a lot further to some of the larger centres.
So who is the sponsor for the study?
It's Arctis and Gilead.
Okay, great. Yeah. Any other questions for Orla? All right, we'll move on. Thank you. So well done to everybody today, but particularly the last 4 presenters who've had to sit nervously for the last hour and a half. It's not easy. We're going to go with Trishani Yogaratnam from Tala, who's discussing challenges around tissue testing for BRCA mutations in routine clinical practice for prostate cancer.
Hi everyone, my name is Trishani Yogaratnam. I'm an oncology and palliative medicine registrar working in Tala University Hospital, and today I'll be presenting on challenges around tissue testing for BRCA mutations in routine clinical practice in prostate cancer. So we know that alterations in homologous recombination repair-associated genes are prevalent in metastatic prostate cancer, BRCA2 mutations being the most common. Germline BRCA mutations are prevalent in about 3 to 8% of patients with metastatic prostate cancer, and somatic BRCA mutations alone are present in up to a further 10% of patients with metastatic prostate cancer. Testing for BRCA is important. It provides prognostic utility. We know that patients with BRCA mutations tend to have worse outcomes overall. It predicts response to PARP inhibitors, and it provides us an opportunity to counsel patients for cascade testing if these patients harbor germline mutations. So the NCCP guidelines mandate testing from castrate resistance onwards. However, we would be advocating for testing from before that, when patients are still in the hormone-sensitive phase. This prevents delays in treatment decisions. We know from Triton-3 in the Breakaway trial, PARP inhibition early in castrate-resistant prostate cancer is preferable. We also know that BRCA mutations are early driver events, and so we can test for these patients when they're still in the hormone-sensitive phase. We don't have to wait until they become castrate-resistant before we test for them. So our aim was to identify the incidence of BRCA mutations in patients tested in Tala University Hospital and to determine the success rate of somatic BRCA testing. We included patients with metastatic prostate cancer with a germline and or somatic BRCA testing requested since March of 2023. This is when it was available in Ireland. And patient particulars were interrogated from electronic patient records. So 60 patients were identified for testing, and ideally 60 germline samples and 60 somatic samples should have proceeded to testing. All 60 germline samples proceeded to testing, but only 46 of the somatic samples proceeded to testing. This is because, number one, 3 of the patients had insufficient tumor cellularity in their samples to proceed to testing. 9 of the patients, we did not have access to their tissue because it just highlights the logistical issues in sourcing off-site tissues or old archival samples. And 2 of the patients already had a germline mutation, and therefore we did not need to proceed with somatic sampling. So out of the 60 germline samples that were sent for testing, 4 patients, so 7% of our patients came back with a pathogenic BRCA2 mutation. 2 of the 4 had no family history of cancer. Out of the 46 somatic samples that proceeded to testing, 20 of our samples, so 44% of our samples failed testing due to insufficient quality or quantity of the DNA. 1 patient had a somatic BRCA2 mutation, and this patient also harbored a germline mutation. So interestingly, we did not isolate anyone with a somatic BRCA mutation alone. The most common site for tissue sampling was the prostate gland, followed by the liver, and then the nodes. So on this bar graph, on the x-axis, we have the age of specimen in years, and on the y-axis, we have the failure rate. And we can see for samples that are less than a year old, we have an 8% failure rate of the samples. And then when the samples are more than 10 years old, there's an 82% failure rate. So samples less than a year old were statistically significantly more likely to achieve a successful result. Over here on the x-axis, we have tumor cellularity, and on the y-axis, we have failure rates. And there was a trend to higher failure rates with decreasing tumor cellularity, but this did not achieve statistical significance. And so higher rates of success are associated with tissues less than a year old, but very few patients will be castrate resistant at this time. Rebiopsying of metastatic sites brings risk to the patient, and it's not always feasible. Circulating tumor DNA is promising, but it's not reimbursed in the public system. And ultimately, we advocate for early tissue and germline testing in all men diagnosed with metastatic prostate cancer. Thank you.
Thank you, Trishani. Any questions? Gosh, I knew it was hard to get tissue and get it tested, but your results are shockingly bad. I'm sure reflective of what we would all find, not just Badentala. That's really disappointing, but there you have it, and really good to know that the recent lesson when your biopsies are the fresher tissue works better.
Yeah.
Any questions?
Testing panel, do you just test for BRCA1 and 2 or the entire extended HLT panel, or?
We focused on BRCA1 and 2, but we also tested for ATM mutations as well. But the purpose of this study was just BRCA1 too, so I'm not sure about the extended HRR mutations. Cool.
Great. Okay, thank you very much.
Thank you.
I think Clara is going to tug at our heartstrings. The title of our abstract is It My Last Christmas? Using Real-World Data as a Prompt to Reflect on Goal Concordant Advanced Lung Cancer Care, a Retrospective Longitudinal Study by Clara Forrest.
So good morning, my name is Clara and I'm an SHO in Cork. So I'll be presenting our study which utilised real world data as a prompt to reflect on goal concordant advanced lung cancer care over Christmas. So essentially our study spans a period when advanced lung cancer care has changed very significantly. However, treatment still includes prolonged courses of systemic therapy. And the time toxicity related to these long treatment courses is very well recognised, with studies showing that advanced lung cancer patients interact with the healthcare systems 1 in every 3 days. And weighing toxicities and benefits of systemic treatment is highly individualised. Research has shown that some would accept toxicities for a survival benefit of just 1 week, while others would decline for a survival benefit of 2 years. Ultimately, patients want care that is concordant with their goals, and physicians want to be able to provide care that is evidence-based, but our evidence base comes from clinical trials that don't always reflect clinical practice. In fact, the median survival of metastatic lung cancer patients treated in the real world is 25% less than those treated in clinical trials, and this efficacy-effectiveness gap reduces therapeutic humility because it leads to an overestimation of treatment benefit. Treatment breaks may constitute goal concordant care for certain patients. And Silverman et al. Found that 55% of patients receive systemic therapy during their last Christmas alive. And while treatment breaks in themselves are poorly studied, research has shown that intercycle delays have not adversely affected outcomes in these cases. So a constellation of these issues prompted our study. We sought to quantify the number of patients who received systemic therapy during their last Christmas alive, and secondary objectives included 30-day mortality and treatment characteristics. We conducted a retrospective study looking at non-small cell lung cancer patients who attended for infusional treatments in the month of December. So those on oral agents were omitted, and palliative intent was cancer that was not surgically resectable or suitable for radical dose radiotherapy. Patient and public involvement was central to our study to ensuring that the interpretation of our findings applied to advanced cancer patients. So in terms of results, we had 250 patients over the study period with a mean age of 65.5 years. Most were adenocarcinoma and most were stage 4. And in terms of our primary objective, we found that 133 of those 250 received palliative systemic therapy during their last Christmas, constituting 53%. Conversely, I suppose if you flip that, 117 lived to the following Christmas, or 47%. And when we look at that percentage who lived to the following Christmas over the study period, it increased as the years went on, in keeping with what we know about improving treatments and outcomes. As I said, our study spans pre and post immunotherapy, and so when we look specifically at our patients between 2006 and 2016, 25% were alive the following year compared to 60% between 2017 and 2023. And 4% of those 133 who did die died within 30 days, and 5% spent their last Christmas admitted to hospital, so thankfully quite small numbers. I suppose 60% were receiving first line of the 133 who got systemic therapy during their last Christmas alive, and 20% were receiving maintenance treatment. But again, looking at 2017 to 2023, that number who are receiving maintenance treatment is increasing. So our key points are that over half of patients received palliative systemic therapy during their last Christmas. And while we did find that the proportion alive the following Christmas increased over the study period, I think these results still highlight a greater need to consider whether the care that we're giving patients is concordant with their goals, particularly during significant life events such as Christmas. And we need to reflect on the appropriateness of systemic therapy timing for advanced cancers. I suppose our future research would like to focus on how concordant is the care we're currently giving, and expand the evidence base for treatment breaks for shared decision making. So I think we're one of the first studies to look in this area. We had good PPI and interdisciplinary involvement with our palliative care colleagues. I suppose we are very limited by the fact that this is retrospective and we can't say what these 250 patients would have liked. But like I said, that's our area of prospective research, hopefully going forward. So thank you for listening, and thank you to those involved.
Thank you, Clara. Very thought-provoking. Cheyne?
Thanks for that. It's very interesting, actually. What do you think the impact will be of giving the patients who want a break for the entire month of December on your day ward in the new year?
Yes, we spoke a little bit about the demands on the day ward, and I think treatment de-escalation in a kind of a global sense is obviously important areas of research. It may not be funded as much as other areas. And so I suppose we just kind of looked at treatment breaks specifically in those with metastatic or advanced cancer and whether it would align. And yes, it would alleviate, but I think what's more important about it than day ward considerations is what does that patient want? Does this align with their goals? Like I said, some would accept the toxicity of treatment for a survival benefit of just 1 week. So we couldn't be asking those patients to take a treatment break just for the sake of our day unit during Christmas.
Yeah, like Christmas poses huge challenges, obviously, for day units trying to reschedule patients. So, all of those patients who have a break for an entire month of December will have to have a home found for them in January and in the new year. That's the point I'm making.
That is true, yeah.
Did your data capture people, I'm just thinking in my own practice, who may have had treatment the first week or two of December and then I gave them a break until January, so I call that their Christmas chemo holiday.
Yeah, we for the
Christmas started early in Cork.
Yeah. For ease, and once we looked at the whole month of December, I suppose in hindsight, we could have looked at a little bit, but we wanted numbers, and we had a nice period of 2006 right up until 2023. Now that 2024 Christmas has happened. So we did look at all of December, but and I suppose the lead up to Christmas is actually part of the nice thing as well, isn't it? Around December.
It is. And how good are clinicians at knowing when this might be a patient's last Christmas or last month?
Yeah, so I suppose that's the difficulty, isn't it? Prognosticating. And patients want to know, what do you think? Do you think I'm going to be here next Christmas? So I suppose all of that data comes from clinical trials, and they're, that whole scope is changing so much over the last couple of years. So you can just estimate if they are asking that, but it's hard to know.
Okay, thank you, Clara. Great. Thank you. Now we have Shauna Moore-Davis from Galway. Picture this: using visual aids to improve communication between oncologists and their patients.
Thank you so much. So my name is Shauna Moore-Davis, and I'm a SHO in University Hospital Galway, and I perform this research with Dr. Chu, and its title is Picture This: Using Visual Aids to Improve Communication Between Oncologists and Their Patients. So medical language can often be esoteric or confusing to patients. This can lead to communication errors and patient dissatisfaction, and it's easy for clinicians to overestimate a patient's health literacy and their capacity for retention of information during consultations. And particularly relevant to oncology, a patient's negative emotive state can also further negatively impact this. So in current practice, clinicians predominantly rely on verbal communication with written communication as an adjunct. However, a patient's recall ability has been previously cited to be as low as 25% after verbal communication. However, the addition of a visual cue can potentially double this. So we performed a cross-sectional study investigating the impact of using pictures as an adjunct to verbal communication during oncology consultations. So visual aids were introduced into clinics from July of last year. And in the beginning, we included just new breast cancer patients and patients attending treatment change visits. So then patients were approached in the Poor Young Hospital day ward following this, and we invited them to fill out voluntary patient satisfaction questionnaires. So the data was collected, and we performed descriptive statistical analysis using Microsoft Excel. So these are just an example of some of the visual aids that were introduced into clinics. So the results of the study, 50 questionnaires were distributed. There was a 57% response rate, so 27 patients total were included, 18 female and 9 male, and the median age was 66 years. 81.5% of patients attended clinic with a family or friend. 29.6% had consultations where the visual aids were actually utilised. Patients were also requested to write down their cancer type and their cancer stage, and interestingly, only of 52% of patients were actually unsure of their cancer stage or their treatment goals. The results of the people that used the visual aids, 88% found them helpful in remembering the information discussed, 87.5% found them helpful in remembering their treatment schedule, and 75% found it helpful for explaining to family who were not present during the consultation. Of those who didn't use the visual aids, 74% believed that they would be helpful as a memory aid, and 100% of those who attended the clinic alone felt that they would be helpful in explaining to family members who weren't present for the consultation. And then interestingly, 72% of the visual aid non-users found the amount of information discussed during the consultation overwhelming, compared to only 44% of those who used the visual aids. So those who use the visual aids were also significantly more likely to be able to cite their cancer stage and treatment goals, 62.5% versus 42.2%. And also we found that patients with a third degree level education were far more likely to be able to cite this information than people that had a maximum of a primary or secondary level education. So with the success of the visual aids among the newly diagnosed breast cancer patients, we would like to expand this to other cancer types in the near future. So in conclusion, patient attitudes towards the visual aids was overwhelmingly positive. We saw particular benefit through their use as a memory aid and as a means of communication to family. Education status had a notable effect on patients' knowledge of their cancer stage and treatment goals, and the visual aids appeared to help bridge this gap. Visual aid users were also less likely to feel overwhelmed with the amount of information discussed at the consultation. So that's the end of my presentation. Thank you so much for listening. And this final slide is just an example of some of the positive feedback that we received from some of the patients that participated in the study. Thank you.
Are you willing to share your visual aids?
So I suppose we didn't design the visual aids ourselves, that they were taken from the Dandelion Toolkit, which is a toolkit used across some centres in the US. They were adapted slightly for the Irish population, but yes, I think
we'll talk.
Yeah. So I was going to ask, how did you do the graphics and, the fancy digital stuff? Oh, we ask.
Sorry.
We'll give you the first pass of answering and then.
Like I said, they were derived from the Dandelion Toolkit, which is a pack that's used over in the US across some centres, and it uses dandelions as a metaphor to describe cancer stages, prognosis, treatment goals for patients, and breaks them down into easy to understand metaphors.
And is there some software platform that you log into and adapt, or?
I think it's a online, software pack that's available.
Anya, do you want to tell us?
Yeah, so the Dandelion Toolkit is mainly for breast cancer patients, which is commonly used in New York. And it's the toolkit itself is an online version, which can be found on their website. But we also tweaked it slightly for the Irish population to include other cancer types as well.
And is that stuff free and free of copyright? You can use and edit it yourself and share?
So in the toolkit, you can order the toolkits, which you do have to pay, but they do have a free version PDF-wise on their system.
Great. Okay, thank you very much. Well done. Poor Christopher. Our last presentation this morning is from Christopher Cluxton, Falls in Cancer, modifiable risk factors to improve cancer outcomes for elderly patients. It's for your patients.
Right, thank you. My name is Chris Cluxton. I'm an SPR in Waterford. Today I'm going to talk about falls in cancer and the modifiable risk factors that we can address to hopefully improve outcomes for older adults. So we know that falls are a major public health concern and often result in serious injury, in particular for older adults. It can result in functional decline and institutionalised healthcare or admission to hospital. Patients with cancer have additional risk factors for falls, and we know from previous studies that patients who have a fall while on treatment have more risk of chemotherapy toxicity. We also know from other hospital specialists and various other studies that falls are preventable and reversible. Our hypothesis is that falls in older adults with cancer will be associated with modifiable risk factors and will impact our treatment decisions or are associated with treatment decisions that we have made. We therefore aim to identify these reversible risk factors and assess the association between falls and systemic therapy prescribing. To do this, we performed a retrospective analysis of newly diagnosed patients age 70 or above in our Gold Clinic in UHW. The data was collected over a 70-month period to December 2024. And each patient had a comprehensive geriatric assessment, including a falls history. A positive falls history was when a patient reported a fall in the preceding 6 months. This is our study population. We had a total of 397 patients. 69 of these had reported a fall in the last 6 months, which is 17%. Most patients had a GI cancer at stage 3 or stage 4 and were being treated in the palliative setting. We identified a number of modifiable risk factors, and we found that patients who had falls had poorer scores for mobility and functional status. So this would be our timed up and go and our CATS and Lawton indices. These patients were also at higher risk of polypharmacy and had more comorbidities as per the Charleston Comorbidity Index. Patients were also at higher risk of malnutrition and low mood and depression, although these two scores we feel met numerical but not statistical significance. I've highlighted here a number of the relatively easily reversible or manageable risk factors for falls, and these are generally identified by our Gold Clinic MDT. We then looked at falls and how this relates to treatment decisions. And we found that falls overall, or patients who have had a fall, receive systemic therapy only 46% of the time. And of those patients who received systemic therapy, 44 required a baseline dose reduction. Of those patients who did not fall, they received systemic therapy 64% of the time. And of those patients, 1 in 4 required a dose reduction. So if we compare these two groups, so patients who experienced a fall, only 1 in 4 received optimal dose systemic therapy, while those who did not have a fall received systemic therapy at optimal dose, full dose, half of the time. So in conclusion, we know that falls are associated with modifiable risk factors, and we know that they are associated with fewer people receiving systemic therapy and higher rates of baseline dose reductions. And how can this inform our clinical practice? So by identifying patients with falls with a brief falls history, patients can be identified as high risk early or at an initial diagnosis. They can then be referred to the medicine for the elderly and allied health professionals to address modifiable risk factors and hopefully eventually develop a prehabilitation pathway for these patients before they reach decision making for systemic therapy. So our proposed outcomes are potentially improved suitability and tolerability of systemic therapy and predicted improved quality of life for all patients. I'd like to thank the entire team at UHW, in particular the GOAL team, and our project lead, Dr. Anne Horgan.
Great.
Thank you.
Question for Christopher? So whose responsibility is to reduce the incidence of falls going forward? Does it fall on us, their clinicians in the hospital? Does it fall on their families? Does it fall in the community?
So I suppose in the GOAL clinic, we identify these risk factors and we engage with the MDT engage with the patient to improve these risk factors, preventing falls as one of the outcomes. I suppose in this study, it's a long way off, but the proposal would be that at initial diagnosis, so whatever team was to initially identify a cancer, the initial diagnosis before they even get to the medical oncology clinic, a quick falls assessment could identify patients that are high risk of not getting to systemic therapy. So heightened awareness at that stage and maybe referral to medicine for the elderly colleagues and allied health professionals at that stage to maybe perform prehabilitation before we make systemic therapy decisions.
And for patients identified as being frail or at falls risk who are not given the opportunity of chemotherapy at baseline and perhaps go away and have MDT input and maybe they get stronger, do they have an opportunity to be reassessed?
So we generally leave the door open, but generally patients that have been assessed as not suitable for systemic therapy often generally decline over time, even with MDT input. Yeah. So.
Any other questions?
Yeah.
Yes, sorry, Angela.
Yeah, really interesting. There was a very interesting finding this week published by the Tilda Research in Trinity, and it was talking about the fact that older people who own dogs and regularly walk their dogs are at much reduced risk of falls. So I'm just wondering, it'd be very interesting to see if there was any correlation with your cohort.
Yeah, so our team are actually doing a study on sarcopenia at the moment, and results are pending. Yeah.
Okay, thank you very much.
Lovely, thank you.
Great. Thank you, everybody. That was a lovely morning. It's always so heartening to hear and to see the diversity and the breadth of research and work going on. And we know that you are all looking after our patients and are clinically busy day after day. And this is done in the small hours of the morning and late at night on a Sunday. So thank you, and full of us for everybody for a great job this morning. I would like to invite, just when I finish speaking here, all of our speakers to come down for a photo of all of our speakers this morning. We have a coffee break until 11:30, and I would invite everybody to peruse the posters. And for our adjudicators, if you can write down your top 3 posters and provide it to myself or the organisers, we'll have some prizes which will be announced at the end of the day at about 4:15 this evening. We'll be announcing our top poster and oral presenters. Thank you, everybody, for a lovely morning.